thanks to the rest of the panel for a great introduction to the numerous issues we have here from the regulatory and economic and delivery of medicine to patient perspective. What I'd like to do is give you a little bit, I don't know, are we switching to my slide deck? That's not me. Thank you. Wouldn't be the first time, but I made such pretty slides. Jokes. Horse walks into a bar. Bartender says, "Hey, buddy, why the long face?" Sorry.
They asked for a joke.
Oh, sorry. You'll be laughing about that later. Yes, it'll hit you like at lunchtime. All right. So, a little bit about who AmerisourceBergen is. We're a 153 billion plus year company, 21,000 associates, and we are a global corporation operating in over 50 countries. For what we do on a day-to-day basis, we have distribution centers for both human and animal health, drug storage depots, specialty clinics, specialty pharmacies. We do have compounding centers as well, just to give you a little idea of the size and scope. Every day, over 3 million medication units are shipped from one of our distribution centers. We service tens of thousands of healthcare provider customers, and that's, again, both in human health and animal health, protecting the health of the food supply. We are the largest distributor of specialty products in the U.S., so things like oncology, biopharmaceuticals, vaccines, dialysis, plasma products. Hundreds of millions of dollars in transactions every day, like from my customer over here. So every day, pharmaceutical distributors sustain a complex supply chain, working around the clock to help pharmacies, hospitals, long-term care facilities, clinics, other healthcare providers across the country keep their shelves stocked with medications and products that patients need every day. We purchase those medications directly from manufacturers, store them in licensed distribution centers, and then deliver that to our customer base on a daily basis. In times of emergency, we serve a critical role ensuring access to necessary medications and medical supplies to facilities that are within disaster zones. So we had a lot of experience with that last year. We coordinate response efforts with public and private partners, facilitate interim solutions until normal operations can be resumed. We work with our supply chain partners ahead of time to figure out in advance of a storm, assuming it's something we have advance notice of, how do we pre-position? How do we have the customer order heavy in advance in anticipation we may not be able to deliver for a day or two? So after an emergency, obviously we coordinate with federal, state, local, tribal, territorial, NGOs to make sure that that medication gets to where it needs to go. This is a bit of a problem, though. And this slide, which I sent yesterday morning, I got an email on the way here on the train. That number is actually 5,400 now. So the number of items that are either not available or that are in allocated supply, meaning we can't get as much as we want or need to satisfy customer demand, increased significantly over the last year. And a large portion of that increase was following the October 2017, after the hurricanes and wildfires and everything else. This market obviously has not improved if that number went up between yesterday morning and when I got here. So why are there product shortages? So give you a little bit of a different perspective. Some of this will be economics, not that I want to step on the good professor there. Some of the experiences, though, that we've had and have already been mentioned, issues getting API, issues at production facilities. Typically, the generics market, you see more of those production anomalies, quality control issues, things with machinery that takes 18 to 24 months to produce and get qualified. Weather and natural disasters obviously has, and has been mentioned already, the Baxter injectables market. But the economic side of it is there have been a number of high-profile instances where the cost of a particular medication has been increased significantly. And that cascades down to, well, I can't even increase the price of a product by 10 cents per pill. And the cost of manufacture, because of the competition in the generics marketplace, you get additional competition there. Many times it's the original manufacturer that did the discovery, development, commercialization of the product. They look at how much it cost, and they decide, you know what, there are other manufacturers coming into this. We can't continue to produce a product that we lose money on, so they exit the market, which increases the problem with shortages. SKU rationalization is essentially what that's called, and as Professor Byrne talked about, the competitors, the footprint of manufacturing for those companies is shrinking because they're looking at the bottom line. This is an economic problem. Full resilience and redundancy in manufacturing capability. 20 years ago, no, it didn't really exist then either, but there was a much larger supply of safety stock in the supply chain. You could go a much longer period if there was an interruption. You potentially had weeks or months of product in the supply chain. It's down to days now, again, driven by economic factors. And not to pick on FDA, that is not the intention of this at all. When a 483 is issued, when do we find out about it in the supply chain? You know, it's not immediate. It's right before the crisis happened. That, what do you mean we can't get the product? And that's when we tell you that we can't send it because we just found out that we can't get it. And then DEA does have annual allotment quotas. That's a whole different topic. I'm not going to get into that, but you know, how do we deal with one crisis without creating another one, without being able to satisfy the legitimate medical needs of an aging population? So what does that mean for us? What are we doing in this space? So we have a product access task force that every day reviews the things that we're not getting. So back order reports, shipping reports, the FDA shortage reports. We try, to the best of our ability, to add days of inventory for things that are in short supply. Extremely difficult if we can't get it. We have been meeting with the suppliers, in particular the injectable market, which is the largest concern that we have now in terms of supply problems. We do meet with the manufacturers individually because we have a relationship with all of them. That's where we fit in the supply chain. So from the sourcing side, we buy from them. We make sure, or we try to make sure, on behalf of our customers and their patients, that we get our fair share of what's available in the marketplace. And to the best of our ability, you know, we have geographically dispersed distribution centers because it's cost effective to do that. If we only have a product in 2 or 3 of our distribution centers and it needs to go to the other side of the country, our costs for air freight, you know, we're, again, an economic issue, are up over 300%, trying to continue to meet market demand. So that's from the sourcing side. From the customer side, we do have a fair share allocation program. So what does that mean? Well, for customers who use AmerisourceBergen as their primary supplier, we attempt as best we can to manage this. Our secondary customers are not eligible because, oh yeah, it's product shortage. We don't have the ability to do that. Anything that is in short supply is allocated based upon historical demand. There's sophisticated formulas that I don't even understand myself, but it discourages stockpiling by a small number of customers. It ensures that, you know, the small pharmacy down the street from you is not shut out by some of our larger customers. It's all proportional. But again, it's still based upon what's available in the supply chain. So this workshop is about disasters. So I obviously have to put in a plug for our Global Business Resilience Program. This is all about proactively safeguarding the interests of our patients, keeping us in business. So business continuity, how do we keep doing what we do regardless of the circumstances? How do we respond to emergencies and manage through crises? How do we keep our IT systems up and running so that that's not a cause of a shortage in the marketplace? But disasters do happen. Last year, as I said, we had a number of learning opportunities. Things that we commonly experience, well, we need power, we need telecommunications, we need fuel. If we have those, we're in great shape. If not, we go to plan B, C, D. Like in Puerto Rico, who plans for total infrastructure destruction? You know, I mean, that was above and beyond. Although I will say, we have a distribution center in Guaynabo that was operational the day after Maria hit. We didn't have a whole lot of customers to deliver to that day, but we were back in operation. Access, so getting through roadblocks, dealing with curfews. Most of what we do occurs when you're sleeping. So orders come in from customers at the end of the day, pick, pack, and ship overnight, and they're delivered in the morning. Credentialing, if that is ever solvable on a national level. Ultimately, it's up to the sheriff's deputy who's at the roadblock whether or not to let our truck through. And coordination. You know, this workshop is a great opportunity for us to talk about who we are, what we do, who we coordinate with, what do we do with HHS, reaching out to the private sector. Administrator Long at FEMA has been doing a lot of that as well. So it's encouraging to see that. We are all in this together. The one thing, though, that I want to stress, from our perspective, a disaster is not an impediment to us delivering product to our customers and patients. In Houston, we have a distribution center in Sugar Land, just to the southwest of Houston. Helicopters, duck boats, Cajun Navy, we're getting the stuff to where it needs to go. Puerto Rico, we chartered a 767 and flew replenishment product in there. We bypassed the backlogs at the airport and the ports by using smaller vehicles. So we didn't need to get a big truck in there to transport. We'll send 4 smaller vans and still get the job done. So if we have the product, we will get it to where it needs to go. Our biggest issue is we're having difficulty getting the product. And as I said, that's a rather complicated issue. Some of the potential solutions that were mentioned, you know, changing or extending expiration dates, importation. I hope we get the opportunity over the next couple days to talk some more about that. They do have some benefit, but there are a large number of challenges to the supply chain being able to ingest some of those things. So if product is brought in from Australia, doesn't have an NDC on the, we can't do anything with it. It doesn't fit into the system. It's not scannable, that you can't scan the bracelet on the patient, scan the medicine, and prevent medical errors. So is that a solution? Well, it may be the start of a solution, but it's definitely something that, that needs to be further explored and worked through. So with that, I guess I will turn it back to you, sir.